So continuing on with Learning Plan 3, we're now on Chapter 14 in Varkarola's Depressive Disorders. So depressive disorders, and there are several of them that we're going to discuss, all share symptoms of sadness, feelings of emptiness, sometimes irritability can go along with that, somatic or body concerns, and we did talk about somatic issues when we were talking about the anxiety learning plan. So really, they're very similar. So bodily concerns, anytime you hear somatic, it refers to the body. And impairment of thinking. So sometimes people really have a serious lack of concentration to the point where you might think they have cognitive issues going on. And these all impact a person's ability to function. So delirium, dementia, and depression, it is one of the competencies to kind of get a feel for the difference between these three. So depression is on the next slide, but just to kind of go through and compare a little bit, because honestly, sometimes it's difficult to tell the difference because there's a little bit of crossover in some of the symptoms. Many times, physicians will order cognitive testing. We used to do the mini mental status exam. Some of you might be familiar with that. I know that they do that in nursing homes to kind of assess a resident's cognitive level to see where they're at as far as their, maybe developing Alzheimer's or another issue similar to that. But we now it's called the MOCA, M-O-C-A. It's very similar to the mini mental, but it's basically a tool that's used to assess somebody's cognitive function. And you can tell if somebody is developing dementia related to that tool. So many times a physician will order that tool on somebody who comes in for a diagnosis of depression if we suspect that there could possibly be some dementia going on. So there can be a little bit of crossover. It can be difficult to distinguish between these three issues, but there are some differences. So delirium, there's a sudden onset, usually hours or days. And if you work in a nursing home or have had clinical in a nursing home, which I know all of you have had at this point, you probably have noted residents that all of a sudden their mental status changes. They might start hallucinating, picking at the air at things, talking about things that don't make any sense when usually they were pretty clear. So many times the issues that we see in nursing homes could be they could have digitoxicity or a toxic reaction to any type of new medication. They could have a UTI. They could have, if they've been to surgery recently, they could have a reaction, even a delayed reaction to the anesthesia. They could also have fluid and electrolyte imbalances. So any of those things, and of course there are more, but that's just a few examples, can cause delirium. So usually a sudden onset. And again, many causative factors, and usually their cognition is fluctuating. So there might be some times during the day, during the same day, there might be some periods of time where they actually look pretty good. They're sounding like their usual self. They're pretty clear and coherent, and then all of a sudden they change. The next hour you go see them, they are completely different. And again, they're picking at the air, they're talking nonsense. So it tends to fluctuate during the day. Delirium is reversible with treatment. Dementia, the onset is very slow. So that's kind of the main difference between delirium and dementia. And again, many causes, usually Alzheimer's, some neurologic or vascular diseases, head trauma, and they have impaired memory and judgment, and it is not reversible. And the impaired memory and judgment usually just keeps getting worse and worse. It doesn't fluctuate the same way delirium does. And then in depression, the onset may have been gradual, and it exacerbates during periods of stress. So again, the gradual onset, kind of similar to dementia, causes many times, if they have a personal history of previous episodes of depression, they are likely to have future episodes. Possibly personal losses, crisis, other medical conditions can precipitate depression, and certainly that genetic predisposition. Patients with depression can be very forgetful, inattentive, have difficulty concentrating. So that part might look a little bit like dementia. So it is important to use a screening tool such as the MoCA to kind of figure out if that person has, a cognitive deficit going on, or if it's part of their symptoms of being depressed. And it is reversible with treatment the same way that delirium is. So just some similarities and differences between those three. So we have different depressive disorders that are classified. Major depressive disorder is the most common. That's the one that you're going to see in clinical the most often. There are other depressive disorders. There is something called disruptive mood dysregulation disorder, and we're going to go through all of these in the next couple of slides. Persistent depressive disorder, which used to be called dysthymia. Anytime you see the word thymia, it really does relate to mood. And euthymic, EU thymic, means a normal mood. Cyclothymic, we kind of just talked about in the last chapter, and that's when people have bipolar disorder and their mood really fluctuates in cycles. So dysthymia is a persistent depressive disorder. Premenstrual dysphoric disorder, substance or medication-induced depressive disorder, because sometimes medications that are prescribed can actually cause depression as a side effect, and certainly some substances can also cause a depressed mood. I'm talking about illicit substances, or even alcohol is actually considered a depressant. There is something called depressive disorder due to another medical condition, and a seasonal affective disorder, which actually is kind of a subset of major depressive disorder. But usually seasonal affective disorder isn't quite as severe. The symptoms aren't quite as severe as with major depression. The one thing I want to say before we kind of delve into all of these is that depressive disorders people really have a lot of stigma attached to these. And if someone is suffering from a depressive disorder, many times there is very little understanding from their friends and family members, unless, of course, they're educated. But it's very easy to stigmatize somebody with a depressive disorder because it may seem like they're just making a choice not to be active, not to do something, not to get up out of bed and take a shower, not to go to work, not to get up off the couch and do the housework. So it really seems like, to some people who aren't educated, that it's a personal choice that they're making. And many people just can't understand why they can't just snap out of it, get up and do what you're supposed to do. It's not that easy. It actually is an illness. There are signs and symptoms, and medication usually is the best treatment. And we'll talk about some other adjunct treatments that might also be useful, but many times medication is the most valuable type of treatment. So unless somebody is not able to tolerate medication, and then we're going to talk about some other types of treatments that are available for depression. But people that are depressed really suffer from people stigmatizing them and judging them and making them feel like they really should be just able to get up and snap out of it. Not going to happen. Little case study, and we'll talk about this kind of throughout this chapter. Jeff, 19, is brought to the hospital after a suicide attempt. His parents found him in his backyard wearing his favorite black jeans and black t-shirt, but with one of his father's neckties. He had overdosed on some of his mother's pills, but his stomach was pumped in time. He had just been admitted to your floor for a 24-hour suicide observation. Okay, so let's talk about, we'll think about Jeff later and talk about some of his symptoms. So let's talk about some of these disorders. So persistent depressive disorder. So again, formerly known as dysthymia. It's a low-level depressive feeling through most of the day for the majority of days, and it has to occur for at least a 2-year period, or at least a year in children and adolescents. So you're probably thinking to yourself, wow, that's a really long time not to feel good. And absolutely it is, but in order to be diagnosed, it has to persist for at least 2 years. years. Otherwise, it could be just considered, perhaps if somebody's going through a loss, grief, a stressful situation, they may have some periods of prolonged sadness, but usually they'll get back to their baseline. But if it's going on for 2 years, then people have what we call this persistent depressive disorder. And you have to have at least 2 or more of the following symptoms: either a decreased appetite or overeating, and it's going to be very similar. Some of these symptoms are so similar to major depressive disorder. But the thing to think about overall is when they have this, their symptoms aren't severe enough to warrant hospitalization usually. I don't think I've ever seen anybody in the hospital for this disorder. Usually medication and outpatient therapy is sufficient to help that person to feel better. So decreased appetite or overeating, insomnia or hypersomnia, so people having difficulty sleeping or sleeping too much, low energy, poor self-esteem, again, difficulty thinking, concentrating, and maybe feelings of hopelessness. But again, these symptoms aren't as severe as major depression, and many times the person can lead their life. They can work, they can have families, jobs, manage a home, things like that, but maybe just on a little bit of a lower level. They're not going to be doing all kinds of exciting things and engaging in hobbies and volunteer work, and they're not going to have maybe as rich and full of a life as they could if they didn't have this disorder. But usually they are functioning at least on a basically minimal level. Premenstrual dysphoric disorders, so the symptoms cluster in the last week prior to the onset of a woman's period, and that includes mood swings, irritability, some feelings of depression, anxiety, feeling overwhelmed, and some difficulty concentrating. And those symptoms decrease significantly or disappear with the onset of menstruation. Some medications that are available to treat this, including sometimes birth control pills are used, SSRIs are sometimes used, but the big recommendation really includes getting regular exercise, especially aerobic exercise, eating foods rich in complex carbohydrates, and getting enough sleep. Sometimes acupuncture, light therapy, and relaxation therapy have also been helpful to kind of decrease those symptoms. Other depressive disorders, substance-induced depressive disorder. So that is usually when a person does not experience those depressive symptoms in the absence of drug or alcohol use or withdrawal. So they only experience depression during those situations. If the person stops using substances, the symptoms usually resolve. There is something else called depressive disorder associated with another medical condition, and that can be caused by kidney failure, Parkinson's disease, Alzheimer's, and hypothyroid is a really important one to think about. It's funny, I was on vacation recently in Grenada, and when you are anywhere, you are always listening to conversations, not purposefully like eavesdropping, but when you hear something, you are always listening with the ears of a nurse. So I just happened to be walking past a couple of women talking, and one of them was very openly talking about how she believed that she had depression. She went to the doctor and was complaining about feeling depressed, and lo and behold, they checked her thyroid and she was hypothyroid, and she was able to get on thyroid replacement and her symptoms went away. So I couldn't help but overhear that as I was walking past, and it was just a real testament to the fact that we really have to, as nurses, advocate for the patient to get a thorough medical workup when they come in with symptoms of depression, because it's possible that it is their thyroid or, again, any of these other illnesses. So that is a very important thing for us to advocate, that they get that medical workup. The symptoms that result from the medical diagnoses or certain medications are not considered major depressive disorder. And again, if something can be treated or corrected, of course we can't correct Alzheimer's disease. But certainly Parkinson's disease can be helped. There are medications to to manage that. Kidney failure possibly can be helped. Hypothyroid, absolutely. There's a medication that can help that. So if you can manage some of these chronic conditions, then the depression symptoms also should go away. The other condition that we really have to think about as highly associated with depression is actually pain. And during clinical, I would be willing to bet that every one of you will have a chance to, if you don't work with a patient that has chronic pain issues along with depression, we will at least be seeing and hearing about other patients that have issues with that. There's a very, very strong correlation between pain and depression, huge comorbidities. Seasonal affective disorder actually just relates to that lack of light. So we all know, we live in Wisconsin, and we all know what it's like when it's winter and it's dark at 4:30, 5 o'clock, and and how much that affects that lack of sunlight affects our moods. Even if we don't have seasonal affective disorder, it just seems a little bit harder to kind of get that energy and to feel like you can actually accomplish something after 5 o'clock when it's pitch black out. You don't feel like doing things that you might feel like doing in the summer when it's light quite a bit later. So that is something that is definitely occurring more in the northern states. Very little incidence of this in the southern states where there is lots of sunshine. Of course, light therapy is one of the best treatments for seasonal affective disorder. Also, vitamin D is considered to be quite useful, and many of the patients on 1K have prescriptions for vitamin D. And I don't think it's always for bone health. So many times it is to try to help them with their mood disorder. Now, I'm not there for clinical over the summer. I would be interested to see if there still is many prescriptions for vitamin D during that time period. As there is for, well, I guess I'm there in August, but anyways, it seems like during the winter months, I definitely see almost every patient is on vitamin D. So exercise is also very helpful. Actual light therapy is another great treatment for seasonal affective disorder. There is a beautiful large light box in 1K. It's not used very often though, and there are smaller versions that are available. You can just purchase them online yourself. Probably, maybe a couple $100, but if you think about the consequences of not getting treatment, it's actually very inexpensive compared to, time lost from work and just time lost generally in being a productive person. So many people actually order their light boxes at home. They're most effective used first thing in the morning, when you wake up, and you spend about an hour sitting there in the light therapy. You could be doing something else at the same time. You could be working on your computer. You could be reading a book or drinking your coffee, whatever. But they really recommend a certain distance from the light box and a certain time frame. They're usually not recommended to be used later on in the day because then there might be so much activation that you can't sleep very well. So major depressive disorder. So again, this is kind of the main disorder that we're thinking about when we think of depression. It is very common and very often diagnosed in patients that we see in the clinical setting. Usually we see 5 or more of the following symptoms in at least a 2-week time period. So weight loss and appetite changes. Many times the weight loss is really quite significant. So the person could lose 20 pounds in a month, something really significant that's way beyond usual, just like eating healthy and dieting and trying to lose weight in a normal way. This goes way beyond that. They have such appetite loss that they end up losing significant amounts of weight. So when you hear that in report, if you're taking care of somebody like this, that is really something that we need to pay attention to. Sometimes people have appetite changes where they're actually eating more and gaining weight, but usually in major depression we see weight loss and that loss of appetite. Sleep disturbances. Many times they have early morning awakening. They just can't sleep through the night. So they may fall asleep, but then they're waking up at 2 in the morning and then waking up at 3 in the morning and just can't get a thorough, full night's sleep. Fatigue. Of course, when you're not sleeping well, you're going to feel a sense of fatigue. And even if they happen to be sleeping well or oversleeping. Sometimes people do sleep too much also with major depression. They're spending all day in bed, and that's not a really helpful thing too. But they don't ever feel refreshed. They feel that sense of fatigue. They feel worthlessness or guilt, and usually that worthlessness and guilt is not connected to anything based in reality. So they may say things like, I've been the worst father I have ever been to my children. I'm not even a good parent. I'm a terrible husband. I'm really bad at my job. And then you're going to talk to the family and they're going to say, oh my, no, they're a wonderful husband. They're a wonderful father. They do a great job at their work, but they don't see it that way. So that sense of overwhelming guilt. They may even say things like, oh, I've just done such terrible things in my life. And truly, again, you talk to the family and that is not based in reality. It's not quite to the proportion of being delusional, which is a false belief. However, it is just it is a really overwhelming symptom that they feel. They have that loss of ability to concentrate. So that's really an important thing to keep in mind when we're working with patients with depression, because you can't hand them a teaching sheet and expect them to read through it. They may not even be able to read a book. They probably won't be able to concentrate well enough to watch television or watch a movie. They certainly aren't going to be paying attention to anything or concentrating well if you're doing some kind of patient teaching. They may not even be able to fill out their menu. It may be that bad. They may not be able to look at all the choices and actually come up with something. You may have to break it down for them. So, for instance, for breakfast, you may have to say to them, do you want cereal or do you want eggs? Just kind of give them two choices, let them pick one, and then move on to the next thing. They may be completely overwhelmed by looking at an entire menu. So their ability to concentrate really is that bad. So it's very difficult, again, for them to perform tasks at home, to perform their job, to read anything. So that's a really significant symptom that we have to intervene with. They may have recurrent thoughts of death, and that can range from passive suicidal ideation all the way to active suicidal ideation. So passive would mean that somebody just says things like, oh, I just wish I would not wake up in the morning. I have this heart condition. I just wish I would go to sleep and have a heart attack and die in my sleep. So they'll say things like that are passive. They're not actively wanting to end their life, but they would be relieved if somehow their life would just end naturally. So, or they could have all the way up to feelings of self-harm, feelings of thoughts of having, thoughts to commit suicide, and then all the way up to if they're having a plan and if they're practicing their plan. So, suicidal or actually act on their plan. So suicidal ideation really is kind of a range, but those thoughts are really recurring, and they have at least one symptom is also either the depressed mood or loss of interest or pleasure in things that they usually found pleasurable. So that is called anhedonia. And we're going to see that symptom again because that also reoccurs in schizophrenia. So hedonistic is a word maybe you've heard, maybe you haven't heard, but hedonistic means pleasure seeking. So if we have anhedonia, it's a lack of pleasure. So they don't see pleasure in anything. And usually it's in things that they previously found really enjoyable, but now at this point when they're depressed, they're going to say things like, nothing is fun anymore, nothing is enjoyable. They don't look forward to anything. So again, it's persistent for a minimum of 2 weeks to 6 months in order to be diagnosed. You don't want to diagnose somebody prior to 2 weeks, only because, again, it could be just a reaction to some stressor or loss that they've experienced in their life. So it really does have to have a pattern. It's chronic, lasting more than 2 years. Many times is that depressive disorder that we talked about that used to be called dysthymia, that persistent depression. The recurrent episodes are very common. So it is common once you have a major depressive episode, it is very common to have another episode. It actually puts you at risk for having another episode. So big teaching point would be to encourage patients to keep up with therapy and to stay on their medication for as long as their physician recommends. Sometimes if patients just feel better and take themselves off their medication, they can go right back into a very serious, another major depressive episode. Even if people stay on medication and are compliant, there are times that possibly the medication just stops working for them, or they have a period of stress and they may find some of the symptoms returning. It's always good the minute they realize that things aren't going as well for them to get some help immediately and to talk to their doctor and possibly get a medication adjustment. So it is very important as far as teaching. Of course, many different types of diagnosis. People feel like, oh, I'm better, I'm on my medication, I can just go off because I'm cured now. I see that in patients even with blood pressure issues. And I've heard people say, oh, my blood pressure is fine, I don't have high blood pressure. Well, but the reason they don't have high blood pressure is because they're taking their medication every day. Same thing with depression. People need to take their medication every day. Sometimes they may need to take it for 6 months to a year, sometimes longer than that, sometimes throughout their life, especially if they're at the point where they have had multiple episodes throughout their life. It is probably something that they're not going to be able to go without. So really important to think about how recurrent that it really is a chronic disease. The symptoms cause distress or impaired functioning. Many, many hours of work and productivity are lost because of depression every year. And the episode is not attributed to physiological problems. So it truly is a major depressive disorder that is brain-based. And there is absence of a manic or a hypomanic episode, which would then have the person be diagnosed with a bipolar disorder. So the epidemiology, again, it's the leading cause of disability in the United States. On page 245, there's a paragraph kind of at the top left-hand side of that page that really talks about the extent. In 2014, it affected approximately 16 million adults in the United States, or about 7% of the population. So that is really very significant. Again, 20% of the cases become chronic, and about 50% of people have a recurrence within the first year, and 85% lifetimes within their lifetime have a recurrence. So it really is a very significant problem. Children and adolescents, it really has been very under-recognized until probably recently that children and adolescents can experience depression. Even babies can experience depression. And I know that's a really difficult concept for some people to understand. But if you think about things like Maslow's hierarchy of needs, and if the baby is not getting their needs met, they're not getting basic physical needs met, food, water, safety, comfort, care, all those things. And then if you think about back to Erikson and that first stage of trust versus mistrust, if that child's needs aren't being met because they're being neglected or abused, then they're not developing trust. Nobody is bonding with them. So that is so important in the life of a baby, an infant, and that can actually cause the infant to become depressed. A really sad statistic in your book on page 246 talks about individuals between 13 and 18 years of age experience depression. About 11% of those between those ages of 13 and 18 experienced depression in 2014. Wow, that is pretty. That's pretty significant. older adults, we also have to look at older adults because sometimes we think that just depression, it's kind of it's inevitable in old age, and it's just a normal part of aging. It is not a normal part of aging. It actually is common, but it is not something that we should expect that an older adult will experience. So the risk of that depression happening increases as somebody's health deteriorates, and obviously as we get older, our health does start to deteriorate. So 1 to 5% of older adults who live in the community have depression, and it rises to about, again, 11% of hospitalized older adults, or those who are requiring care in their home. Again, getting back to that slide that we looked at a few slides ago about delirium, dementia, and depression, there is something called pseudodementia, and I do remember hearing this throughout my career, that sometimes older patients kind of have this syndrome, and basically it's that we think they're developing a neurologic problem or perhaps Alzheimer's, but they are actually having a depression. But when you treat the depression, those symptoms, that pseudodementia, really does clear up. So it is always worth it to try to assess older adults for depression. It is harder to assess children and adolescents and older adults for depression because depending on the age and the cognitive level, it is sometimes difficult for those populations to actually express their feelings of depression. And so we kind of have to figure it out sometimes that that's what they're going through. And comorbidities. So definitely depression accompanies many other psychiatric illnesses: schizophrenia, substance abuse, eating disorders, schizoaffective disorder, borderline personality disorder, and anxiety and depression is probably the most common psychiatric presentation. You will see this continuously in clinical. People that have anxiety disorders often have depression, and people that have depression often have anxiety. It is such an incredible comorbidity. About 70% of cases of major depression also have symptoms of anxiety. So it is a very, very strong comorbidity. Actually, in the book, it even talks about some clinicians think that anxiety and depression, as like a combination, should be a standalone diagnosis and treated as a distinct entity. You will definitely be seeing a lot of that when we're in the clinical setting. So again, back to the case study. During intake, Jeff doesn't speak much, but his parents are able to list the following symptoms that they have observed: weight loss and appetite changes, insomnia, fatigue, worthlessness or guilt, loss of interest in his college classes, and even the online games he usually plays with friends. So that could be part of that anhedonia, where he usually enjoys these online games, or maybe he enjoys his college classes, but now nothing seems interesting to him. And just having those feelings of persistent, constant sadness. A little audience response question. Jeff's parents have described his lack of interest in things he used to enjoy, like games with his friends and classes. This may be best described, I think I just told you, anhedonia. So loss of interest in things that are usually pleasurable. Etiology. So biologic factors, we always have to think about having a family history. So people that have family histories of depression certainly are at risk. Again, it doesn't always mean that you are going to develop this illness, but it does have a genetic tendency. So under biochemical, the brain is obviously a very, very complex organ. And two of the main neurotransmitters that we think about for mood and depression are serotonin and norepinephrine. And you're going to notice that when we talk about medications, that many of the medications work on those two neurotransmitters. So serotonin regulates sleep, appetite, libido. So it's easy to see where some of those depression symptoms come from. Norepinephrine kind of modulates attention and behavior, and it is stimulated by stressful situations. So then we can kind of see then the link between stressful life events and your chemicals becoming off balance and throwing that person into a major depressive episode. There can be alterations in hormonal regulation. Sounds like, according to the book, that truly a lot more research needs to be done in this area in order to really understand that. Inflammatory processes, that's another area that more research is being done in, and that we don't think that inflammation causes depression, but it certainly does play a role. And the diathesis stress model. So, and that is really something that takes into account the interplay between the genetic and biological predisposition towards depression and life events. So, having that predisposition and then having stressful life events can sometimes be the precipitant for a major depressive episode to start. Again, the brain is such an interesting organ, and that we really have to think about this diathesis stress model as something that is really highly regarded. So basically, the stressors and those really difficult interpersonal events, they trigger neurochemical changes in the brain. Early life trauma can cause changes in the brain, and that can cause overall, I'm just really summarizing this, that, people can have just more exaggerated stress responses when they become adults. So we do have to look at the trauma that children experience in terms of something that may later in life lead to a depressive episode. We also can think about psychological factors. There's cognitive theory and learned helplessness theory. Cognitive theory kind of assumes that a person's thoughts will result in their emotions. So then that's the theory. The therapy then is kind of designed to help a person change their thoughts in order to change their moods. The nursing process. So assessment. We are thinking about assessment tools that we might use for depression and assessment of suicide potential. The Beck Depression Inventory is one of the tools that I usually put a copy of that in the clinical packet. So you might want to take a look at that in the fall when you're in clinical. You don't really need to look at that now. Let me see. I don't know that I see a copy of that actually in your book, but the hospital uses the short form of the Beck, and actually I also have a copy of the long form. And it's just a series of questions going through to see if people have certain symptoms of depression. There's also something on page 249, and it's called a Patient Health Questionnaire 9 or a PHQ 9. I know that this is used in many doctors' offices to screen for depression. Even medical doctors are starting to use this. OBGYNs, different specialties, are starting to use this just as a basic general screening for depression, even if their patients are coming in for something not even vaguely related to depression. So it's actually kind of good because sometimes people go to the doctor for any number of different types of medical complaints or problems, but maybe they have an underlying depression and they just don't really want to talk about it. But a tool like this can actually pick up on symptoms and maybe get that person to help. So we always want to be assessing suicide potential. That is hugely, hugely important. And I know that that's another initiative that some health systems have already undertaken in terms of really trying to assess for suicide. Again, even when people go to the doctor for a checkup or maybe some other completely unrelated medical complaint, it's great to be screening people for suicidal thoughts and ideas because, again, sometimes you can help someone. I know that there was somebody in clinical this past year that just a patient that came into 1K that just went to their doctor for I don't know what medical problem, and had that questionnaire, it was really determined that that patient was suffering from depression enough to the point where they needed to come into the hospital. So screening is super, super important, and it shouldn't just be taking place in mental health settings. It should be taking place no matter what area that we work in. So that is an extremely important thing to do. Key assessment findings, again, are that depressed mood, anhedonia, anergia, which just means lack of energy, anxiety, psychomotor agitation, or retardation. So when people have agitation, psychomotor agitation, it's usually it's that anxiety component. So again, depression and anxiety really go hand in hand. And many times we see that in the pacing. They're pacing, they're wringing their hands, and it's purposeless activity. Psychomotor retardation is slowed movements to the point where people are in bed long periods of time. Even if they're not sleeping, they are just laying in bed. They can't get out of bed, or if they're at home, they can't get off the couch. Movements are very, very slow. Takes them a long time to get up, get a shower, get dressed, even if they're even able to accomplish those basic tasks. The vegetative signs of depression we have to think about as something that is the bodily symptoms of depression, and I have another slide on that. Again, a huge comorbidity in our assessment is chronic pain. So we always need to look if somebody has pain issues. I've seen people have pain issues to the point where they have felt suicidal if they don't get relief from their pain. So here we go with the vegetative signs, and it's basically eating, sleeping, elimination, and sex. So activities that are necessary to support life and growth. So we do have to pay very, very careful attention to a person's bodily symptoms. Very important to make sure that people with depression are eating appropriately, drinking enough fluids, getting some exercise, just getting good sleep, taking really good care of their bodies. So that's the vegetative signs. Again, back to the nursing process. So other areas to assess their affect, which is what we observe about their facial expression. So if I look at somebody, I can usually read somebody's mood by kind of looking at their facial expression. So it may be, maybe their affect is sad, maybe it's anxious, it could be angry. There's all different varieties of ways to describe somebody's affect. Thought processes, are they clear? Are they coherent? Are they able to express their thoughts logically, or are they slowed? Are they having a difficult time grasping information, concentrating on things, making decisions? Mood is really very subjective, so it's how they describe their mood. We can't look at a person and say, oh, they have a depressed mood. We may say they have a depressed affect, but we really can't say that they have a depressed mood. That is very subjective. So overall, their general feelings, anxiety again is going to go hand in hand with that many times. Their physical behavior, if they're able to accomplish anything, if they're getting in the shower, or if they can't even brush their teeth. Their communication, their religious beliefs, and spirituality. Sometimes religious beliefs and spirituality can be very helpful to a patient in terms of giving them a reason for living, and that faith, if they can draw on their faith, they sometimes will be able to not commit suicide. However, there are some religious beliefs that perhaps are very harmful to a person's mental health in terms of, I know that there's been a patient who comes in every now and then, and her church tells her that she should not be taking any medication, that she should just pray, and that she should try some natural methods, herbals and things like that, in order to get over her depression, when really that isn't something that is helpful for her. She truly needs she has brain abnormalities that go along with depression, and she truly needs medication. But sometimes there might be certain church groups that really frown on and discourage the use of medication. So we have to kind of assess that. It's an important thing for us to take a look at. Again, we have to look at age considerations, and that children, adolescents, and older adults are going to be expressing their depression in different ways. And we always have to look for subtle signs that that person is going through a depressive episode. And again, always go through that self-assessment. It is easy to get frustrated, and again, just think that that person should just be able to get up off the couch and go take their shower, brush their teeth, and kind of function and get over it, and they really can't. So it can be very frustrating. Another frustrating thing about the forming a relationship with a person who is depressed is that they may really not want to have a relationship with you as their nurse. They may not want to talk to you. They may dismiss you. They may pull the covers over their head and just ignore you. So all those things can kind of make a nurse feel bad because, gosh, we feel like we want to get in there and we know we want to help this person, and we're all gung-ho to do the best we can for this person, and they don't seem to want anything to do with us. So that can be very frustrating. The most important way for us to deal with that is to continue to try to work on that therapeutic alliance and relationship. Spend time with that person no matter what, even if they look like they don't want to talk to us. And that doesn't mean that we have to spend, every second with them, but do make them aware that you feel that they are a valuable human being worthy of spending time with. And so sometimes we might even have to schedule time spent with them, and just keep going back and be consistent. If you say you're going to come back at noon, go back at noon. If you say you're going to talk to them before you leave the shift for the day, go back and talk to them before you leave for the day. And believe it or not, even though they may not seem like they're appreciating the relationship, they absolutely are, and they are. When they get better, they will certainly begin to respond to you more. But in that initial period where they're so depressed, we can't expect them to just respond to us and have this great relationship and talk and open up and share all their thoughts and feelings. It's probably just not going to happen right away. And that is something that takes time to develop anyways. Some people are very open and they'll talk right away, but for many people, they need to develop trust. They need to feel you out and make sure that you're a trustworthy person before they share their innermost thoughts and feelings with you. So it is important to have some empathy, kind of feel what the patient is feeling. And that doesn't mean that we lower our own mood to the point of being depressed along with them, but just that we have empathy and we can appreciate and try to understand where they're coming from. So even saying something empathetic like, I can see that you're just really depressed right now. I can see that you feel hopeless, that you feel like life isn't worth living. Just that acknowledgement of what they're going through is actually very, very powerful. Audience response question. Which question would be a priority when assessing for symptoms of major depression? Tell me about any special powers you believe you have. You look really sad. Have you thought of harming yourself? Your family says you never stop. How much sleep do you get? Do you ever find that you don't remember where you've been or what you've done? So I am hoping that you picked B, because that is a very great top priority when somebody is depressed, is looking at their suicidal ideation. So, nursing diagnosis. Again, risk for suicide. Safety is always the highest priority. And it could also be risk for self-harm, because sometimes patients use self-harm as a way to reduce their anxiety and make themselves feel a little bit better, even though the intention is not to commit suicide. But sometimes they are also self-harming. But risk for suicide, definitely the highest priority. Hopelessness is also a huge priority, because once somebody has reached the point of being hopeless, they feel like nobody can help them. Nothing is ever going to get better. They're never going to get well. Helplessness is a little bit different. I don't think helplessness is actually a diagnosis, but just to clarify the difference between hopelessness and helplessness, if you're feeling helpless, you feel like you can't do anything to change the situation or make it better, but maybe somebody else can. Hopelessness, you can't do anything to change the situation or make things better, and nobody else can either. So that is where the hopelessness aspect comes from, where people really don't feel anything is ever going to get better for them. Nobody can help them. Ineffective coping is certainly a huge nursing diagnosis, many times people cope in very ineffective ways. They shut themselves off from other people. They don't seek out relationships. They don't share. They don't talk to other people. They kind of isolate themselves. So social isolation kind of goes along with that. Sometimes people cope ineffectively by, again, cutting, making suicide attempts. All those things that are really not very using substances, all those things that are really very detrimental. So social isolation, they're not going out and being with people like they used to. They may have spiritual distress. They may actually feel like God is punishing them and that somehow they were a really bad person and that's why they feel the way they feel. So if somebody is having spiritual distress, it's a great intervention to ask them if they would like to talk to the hospital chaplain and then try to arrange that for them if they feel that that's something that would be useful. Self-care deficit is actually another huge nursing diagnosis because it is amazing how people with depression don't shower, don't brush their teeth, don't wash their face, just those basic hygiene things that we just take for granted. I do hope that you look in the learning plan. I do have a depression must see. That is a article that I found, and the girl is a teenager who suffered from depression, and she didn't comb her hair, it looks like, for a really long time, and it became just an absolute tangled mess. And she went to the hairdresser just thinking that she'll just cut it all off. She just really didn't even want anybody to bother with it, just cut it off. And the hairdresser took hours and hours and hours and untangled her hair and made it absolutely beautiful, which I'm sure that girl deeply appreciated with her, depressive disorder, that somebody cared enough to spend that kind of quality time with her and help her to increase her self-esteem by improving the looks of her hair. So definitely make sure that you take a look at that. So that self-care, that's probably one of the most extreme self-care deficits I've seen. Actually, though, I have seen a few patients on 1K that come in with hair quite a tangled mess, and there was somebody that I literally thought had dreadlocks, and it turned out that it was not dreadlocks, that it was actually just that the person had not combed their hair for so long, and it was very tangled, and it kind of looked like dreadlocks. So that is something that we really need to pay attention to as nurses, though, that self-care deficit. We always are going to make outcomes related to those problems that they have. And again, the goals really have to be kind of small. We can't go from not getting out of bed and not showering to becoming completely well groomed. So maybe it's a very, very small step that we want to help the patient with. And we always have to include the patient when we're making goals. So skipping down to the fourth bullet point, that the treatment goals are mutually developed. We can't just set goals for the patient. We did that in the old days. Those days are gone. We really need to involve the patient in setting goals. And they need to be based on the patient's personal needs and values. Again, back in the olden days, nobody even told the patient their diagnosis, nor did they ever ask the patient, what do you want out of life? What are your goals? What would you like to accomplish? Nobody ever asked the patient that. That is so basic. And now that is something that is a huge focus. And again, we always need to focus on the patient's strengths because they do have strengths as a person, but they may not be able to recognize them because of their depression. Planning. So we're trying to plan our interventions and trying to get them through their phase of depression, their particular symptoms that they have, and again, the patient's personal goals. So the planning is going to be different based on where the patient is at. If they are so depressed that they have hair that is tangled and hasn't been combed for months and they haven't showered in a couple of weeks, our planning is again not going to be that they are going to be going to 6 groups a day and they're going to get up, shower, brush their teeth, comb their hair, and put makeup on, be extremely well groomed. That's not going to happen overnight. So we really have to look at the phase of depression. The goals are going to change as the person starts feeling better. The implementation. So that's the part that is really the most exciting and interesting when you're working with patients. So that includes your interventions with that patient. So it is always a good intervention to try to encourage the patient to perform activities of daily living, to encourage them to spend time out of their room, to socialize with other people, even just to eat breakfast in the dining room might be a huge goal for somebody. But it is, and you might think, well, that's very simple, it's very basic. But for somebody who's depressed, it might be a huge step to take to actually sit in the dining room and eat breakfast with other patients. So that implementation really is a great area and gives you a lot of satisfaction when we start to see people actually responding and doing better. But just remember, it's not going to just be your interaction, it's also more than likely going to be their medication treatment too. Once the medication starts working a little bit, the person seems to have a better mood, have a little bit more energy, and they're able to do a little bit more things, but they certainly still need us to be encouraging them. So we have three phases. We have the acute, the continuation, and the maintenance phase. Acute phase is usually where we see patients in the hospital, although not usually for 6 to 12 weeks. Again, back in the olden days, we had patients for months in the hospital with a major depressive episode because they would not want to discharge somebody until they were completely 100% better. And that doesn't happen because insurance companies just will not allow somebody to be in the hospital for months on end when they're at the point where they're safe and they're going to have to still recover at home, continuing to take their medications, going to their outpatient appointments and therapy. So that acute phase, we see people usually at the beginning of the acute phase when they're in the hospital, and the goal really is to reduce their symptoms and to try to restore them to some kind of functional ability. So again, hospitalization is usually required, and medication or some other biologic treatments might be indicated in that acute phase. But again, we're not seeing them, at least in the inpatient unit, for the duration of that acute phase. The continuation phase is something that we really have to do a lot of teaching about because, again, unless we work in outpatient mental health, we're not seeing patients in that phase. So we are trying to do some teaching because we want to prevent them from having relapse. So they need to continue to take their medication for at least that 4 to 9 month period after they have their episode, and education and depression specific psychotherapy. Encourage them to take their meds, how important that is, even if they feel better, and encourage them to continue with therapy. Those things are very helpful and may prevent them from having a relapse, especially right away. The maintenance phase then is basically a year or more of treatment directed at preventing further episodes of depression. And depending on the risk factors, medication could be phased out a little bit or it could be continued. It really is so very individual. It's always a good idea to recommend that the patient really, if they want to go off medication, to work with their doctor, not to just stop it suddenly. Well, because actually some of the antidepressant medications can cause withdrawal if they're stopped suddenly. So a medication should always be weaned off under the supervision of a physician. And as they're weaning and they're gradually decreasing that dosage, if the person feels that they're starting to have some of their symptoms return, then they need to talk to their doctor and hopefully get back on an appropriate dosage of medication. So again, it's really very individualized. So counseling and communication, health teaching and health promotion, promoting those self-care activities, and teamwork and safety is, I think we've kind of talked about the other three bullet points a little bit already. But when somebody's on an inpatient unit, teamwork and safety is really very important. So that is one of the main reasons why when we are in clinical, we listen to report on the entire unit. So you hear report on everyone, even if you're not taking care of them. And they even have started to highlight and do like a safety huddle where they talk about people on the unit that are safety concerns, and if it's suicide or perhaps violent behavior, homicidal, whatever. But suicidal behavior or if they're at risk to elope or at risk for self-harm. Those things are all discussed and highlighted so that everybody on that unit, whether they are students or regular staff members, everyone knows what's going on so that we can all help and intervene and keep an eye out for certain situations. So that teamwork and safety aspect is so important on a mental health unit. So, psychopharmacological intervention, so medication. So, choosing an antidepressant. Now, unless you're an advanced practice nurse, we as staff nurses are not choosing the antidepressant. That is what the physician or the other healthcare provider does. So, they're looking for symptoms, the symptom profile. So, thinking about medications, it may target different symptoms. Side effect profile is huge. I know that there was a patient a few months ago who was having some sexual dysfunction, and it was a young man who was married and wanted to have children. He and his wife wanted to have children, and so that medication was not appropriate for him, and they did end up switching him to a different antidepressant that didn't have that side effect. Because how detrimental if you really are at the point where you're wanting to start a family and you're having sexual dysfunction. Weight gain is another thing. That's just, it can be devastating. Sometimes people can gain just enormous amounts of weight, and just think about how that impacts your self-esteem and then the development of other health issues. So it really, again, is really variable. There are some antidepressants that actually help people to lose weight, but some of them do cause some weight gain. So if that's so distressing to the patient or causing medical issues, again, you may have to look at, the doctor may have to look at ordering something a little bit different. The ease of administration. So if it's something that can be taken once a day that's long acting, many times that's a really wonderful opportunity for people because, yeah, it's kind of hard to remember to take your meds 3 or 4 times a day. But sometimes just taking it once a day in the morning or once a day at night can actually be very helpful. Always have to look at the history of their past response and safety and medical considerations. On page 257, there is a really nice diagram of the brain, and it covers the norepinephrine pathway and the serotonin pathway. And then there's a little chart at the bottom that talks about the patient's specific problems and an example of the medication that might be used. So again, we as nurses need to be aware of the medication and how it's working with the patient. We can always reinforce teaching. We are not the ones prescribing unless we are an advanced practice nurse. I am going to stop this recording and continue because this one's over an hour already. So I'll see you in a little bit.